Why don't we continue in if we can, continue with the list that we're going through. And I think the discussion that was emanating from this was really good, and I think really helpful to hear what you have to say, raises issues and learn from each other in a learning community kind of way. I think that's really, really helpful. But we will finish on time for sure. There's other things at the end we can do a little bit less time on, but there's just a few more of these that we can go through. So we talked about the discharge plan and who's going to teach it. So let's talk a little bit for a minute or two about review with the patient what to do if a problem arises. And the issue, some of the challenges are in many places it's hard to know who it is that's responsible for that. And as I said several times this morning, that patients worry a lot about not being able to reach a clinical person in the days after discharge, and then nights and weekends and that sort of thing, and that we all ought to have somebody that we can call who has a reasonable chance of knowing who we are. But lots and lots of people don't. So, just ideas about how the hospitals would be able to deal with this component of RED. Review with the patient what to do if a problem arises. So that has two components. One is what is a problem, and what to do if it arises. Okay, please.
So we're really lucky we have a telephone care program, and the numbers listed on all the discharge paperwork. So if a patient has a problem that arises, they can call telephone care 24 hours and speak to an advice nurse.
Wow.
Somebody left this cell phone in the bathroom, and so if you don't claim it, I'm selling it at the end of the class.
Yeah.
Right back here.
So you really are lucky, and that applies to all VAs. Yeah. And that do people know about that? Are they told about that when they're discharged? Yeah.
We'll hear from a staff nurse about the process with discharge.
Sorry, I'm just saying the nurses go over it with them. We say we highlight it on their paper for them.
Yeah, that's fantastic.
And
you guys really are many, many steps ahead of most places.
Yeah.
And you have the opportunities to.
We specifically talk about what problems to look for as well, and those often get highlighted on their little paper for them.
If a patient belongs to the home telehealth program, we're also another area that they can call if a problem arises, and then we try to guide them through problem solving on their own to build self-management skills, or if it's just too stressful, then we do the navigation for them.
Great. Wow.
Hey, David, I just wanted to know, is this, do you think that this is something that the patient, the aftercare, the discharge aftercare plan is something that could actually be loaded onto My Healthy Vet, so the vets could have an electronic version?
We talked about that. We talked about having that available on My Healthy Vet, and if you've seen some of the Louise stuff, we've even talked about making that available on My Healthy Vet.
He's almost as bad as John with this no mic thing, but the answer, I guess, was yes. Go ahead, John. That's what he gets.
So I would just mention the phone service, I would say, as good as it sounds, our abandonment rates around 15 to 20%, and the average speed of answer is around 2.5 minutes. So it's something we need to work on.
Yeah.
And then that's during business hours. So the after hours, it gets rolled up to a regional call center that has even worse metrics, although they can get into electronic medical record. And unfortunately, they also are directed to use a triage program that oftentimes will trump what the nurse would think. And it's kind of because we haven't yet gotten to our culture is, that doesn't sound right. I'm going to go ahead and say that you don't need to come into the emergency room right now.
Yeah.
It's a very conservative one, but it's a great resource that we have.
Yeah, I wonder, and that's a reasonable research study to do. I mean, because a system like that doesn't know the patient so well will err on the side of go to the emergency room. If they call their primary doctor, the doctor will know the patient, will say, do this, and I'll see you in the morning. That would be worth looking at to see if that actually raises rates or not. Might not.
Here we go again.
Okay.
Give him his own microphone.
I didn't think it was worth being taped, that part. But there's a national Fix the Phone initiative, and it'll be looking at they had a call yesterday about it, and they're going to map out what would happen if it went to the teamlet, to a call center, which types of calls are ones that are kind of more specific to the teamlet that could handle versus business questions, those types of things. It would be a virtual call center for nationally, like Kaiser does. But as one of the things they're looking at, or do you regionalize it and the economy of scale?
Any other comments about that? That's all really interesting. The next is expedite the transmission of the discharge summary to clinicians accepting care of the patient. And this has two components. That means that some sort of a discharge summary needs to be done in a timely way at the time of discharge. And the second part of it is then that document needs to be transmitted to the source of ongoing care later. Hospitals have trouble with this, as I think I mentioned earlier, in that the JCO standard is 30 days where discharge summaries have to be done, and that obviously is not adequate. But changing the culture so that the clinicians do the discharge summary at the time of discharge is important relative to transitions. We were lucky because we started doing our work around the time that our hospital went to a new system where it was required that all patients, it was mostly because the medical record system and everything was all so backed up. We said, let's just forget about all that stuff, and everybody has to do it before they go home. It has to be done. And the chief medical officer was really adamant about, we're doing it this way, and that's the way it is. But changed the name of it from the discharge summary to the discharge resume, thinking that somehow that would make it easier. And it is easier in the sense that maybe it can be shorter. And they emphasize it doesn't need to be this long thing. It needs to have the pertinent, important facts in it that you need, for later care of the patient. And now, of course, there's lots of cutting and pasting and all that sort of stuff that goes on at the time of discharge, and I don't know so much about the quality. So how about ideas from places about, are discharge summaries, one, done at the time of discharge? If not, how are you going to do that? And number two, when they're done, how are you going to get them to the place that's going to follow them up?
Maggie, do you want to comment on your experience with?
So for the VA, it works pretty nifty, except that I'll be honest with you, a lot of times the discharge summary is not done at the time I need to make the call. But when that's not done, the pharmacy note is done. So I can use that in combination with the nursing discharge note to at least sort of get a sense about what is going on. We get a email in our secure email system that notifies me, our PAC team, of a discharge for our team, and it tells me when they were admitted and when they were discharged. So then I know what my deadline is then to try to reach the person. Mm-hmm. And then we'll review the discharge things. What I'm salivating about right now is, one other thing. Oftentimes we will get either a message or a call from the home skilled services for the visiting nurse and that sort of thing, making sure that the primary will accept and will sign orders for that, so that we know that there's going to be home health that's going to be involved as well. But I'm really salivating over, I want the other hospitals in the San Jose community to have this, because it's a big nightmare for us for people to walk in with a prescription list. Oh, I went to regional, and so here, I need these prescriptions. And then there's no other piece of paper. We just have that list of prescriptions. We don't, and if they do have another piece of paper, it's the patient discharge instructions, which is very generic. You can barely tell what they were treated for.
Yeah.
And so if they could come to us with that nice little, booklet, whoa, I would just be in heaven.
That's great. That's great. Our discharge summaries, what's the policy at the VA for when they have to be done?
I think our medical records would might take over 30 days.
Yeah.
Although I believe it might have, I think 14 days might be our.
Yeah, something like that. Yeah.
I think because our residents turn on the 28-day cycle.
They have to do them by then.
It's really never more than 28 days. But I think they've been working on it recently, the last month or two. We've been talking about with our nurses calling, they need that in there. And so I'm not sure if it's been noticeable, but they're trying to do more of it in a more timely manner. But I don't know if that's noticeable now here, but other people are calling.
So one of the Project Red components is to send the discharge summary to the PCP within 24 to 48 hours.
So we know we're not there.
How are you going to do that? Yeah.
John will fix that one after the conference.
Yeah. So, in our system at home, in our practice, we have a staff person who does a lot of the stuff to organize the inpatient service, and that the discharge summaries, when people come into the hospital, he sends a text or a page to the PCP telling them that they are there by 10 o'clock in the morning every day, or by 10 o'clock on Monday for weekend admissions, and then sends the discharge summary to the PCPs when they're done. And another thing is that the discharge summaries, again, for us, are done by the residents, but they don't go into the electronic system until the attending signs them. So we have a CQI system now where the attendings have to sign by 10 o'clock the following day. And we're up to 100% on that. Attendings really know, because we show it to them every Friday. We say, here's your list of discharge summaries and the number that weren't signed by 10 o'clock the following day. So we really pay attention to that, because that holds everything up. And once they've signed it, then it can go into the system. It goes electronically to the PCP, and goes to Nelson, and then Nelson faxes it to them also. So that's the system that we've set up.
Well, we're lucky in some ways in that, other than the situation that Maggie was talking about where they're hospitalized outside, if they were hospitalized in our system, then we can see it. One of the problems that we had a few years ago is exactly the one that you're talking about, that the house staff would dictate it, but it wouldn't show up until the attending signed it.
Yeah.
And I think we worked on that a few years ago so that it could be seen still unsigned. Because, if the patient's discharged at the end of the month, then the attending is someplace else. And because that was a fix to part of the problem.
Right.
So Keith has walked in, and Keith, we're talking about the discharge summary, and where are we at? Do we take 30 days, or we do it in 48, 24 to 48, like is recommended with Project Red? And if we don't do it in 24 to 48 hours, because there are some challenges before us, what are those challenges, and how may they be overcome?
So our standard is to dictate to have the discharge summary complete within 48 hours of discharge.
That's for the hospital service.
Yeah.
Yeah.
We're fairly good at that. We have a person that keeps track of this and sends our chief resident notification of discharge summaries that are more than 48 hours old. And the chief residents, during the resident orientation each month, they're very explicit that they will call the residents with discharge summaries that are overdue. And that's a change. Our current crop of chief residents have really been on this.
Mm-hmm.
So I think that there's definitely outliers. There's those discharge summaries that just plague the interns, and so that's probably, I would say, about 10%.
Yeah.
But for the most part, we're on
continuous
that.
quality improvement. It's a good measure to have, and feed that back in rapid cycles to the people who are doing them.
Yeah.
It changes behavior.
Thanks. You totally changed the picture on that for us. That's great. Thanks.
I can help.
For the community hospitals in the Valley, it's a big problem because here in Palo Alto and not quite as much as San Jose, most of the patients come to the Palo Alto VA, but we have clinics out 3 hours east of here. So they've worked to go meet the community hospitals and set up relationships. So Maureen, our discharge coordinator, is going to introduce her.
This is a sign. We have got to throw that mic in the garbage.
Sorry. But Maureen told me last week, she was like, hey, this is so cool. The hospital called, and do you want to tell them what happened with the patient that had an issue? And I mean, basically showed up in the clinic, needed Plavix, had a stent placed outside, and normally they show up and we have a non-formulary, we have to go through these processes. Was able to contact the doctor, get it all set up before the patient was even discharged from the other hospital, and had it all ready to go. Instead of normally it would show up 2 days later in our clinic, 4 o'clock on Friday, saying, hey, by the way, can I get this? And P.S., we don't have a pharmacy on site there. So it's really nice to be able to reach out to the community, and we probably just need to tag each of them. And as we find out who's doing the red in the Bay Area, it'll be nice to probably touch base with that point of contact and say, hey, we'll help you. You know, we're working on the same thing, by the way. I think it'll be really good. How many folks in the Bay Area are doing it? I don't know. Are there other people doing red here? Do people know?
San Francisco General is already doing Project Red. Alameda County Medical Center is interested. Who else? There's, the San Francisco VA, Santa Clara. Yeah, so I think there's like at least 6 or 7 hospitals who are interested in doing it. You know, whether they actually end up implementing it, because they're still, they're not as far along as you guys are. But we do have this readmissions collaborative that David attends, and if you want to create a subgroup of Project Red implementers, we can certainly do that. We have like a listserv and lots of resources through that collaborative.
Finally, is providing telephone reinforcement of the discharge plan. So challenges are reaching the patients, follow up with the outpatient providers, and then the time and effort and the cost associated with all that. And that how are you going to do it? And we seem as if that there is a system for all hospitals, or some, or which hospitals?
So I know,
Yeah.
Becky, can you just say what the PACs are doing? What percentage of the patients you're calling back in the PACs now? Or
I think the goal was 40%.
The goal nationally is 50%.
Uh-huh.
That includes all discharges.
Yeah.
It doesn't exclude people that go to nursing homes or extended care. It includes mental health, surgery, and medicine. I think nationally, like right now as an institution, we have a compass that gets updated each month. So I think we're around 25 to almost 30% as of July. And some of our clinics are at 50%, but it's interesting, the pharmacist 62% of the time reaching them. We have struggled at trying to reach them. It hasn't been easy to kind of get in touch. But there are some VAs that are over 50% as a whole region calling. There's a couple of them.
So all of our packed RNs are making discharge follow-up calls, but not at a 100% level. But everybody, we have 5 packed RNs, and everybody's doing calls.
And additionally, Peggy Brandon makes calls to 100% of our discharged patients. She doesn't get in touch with 100% of them, but yeah, discharge to home. That's the only kind of discharge we want, right? But you want to say, what do you do when you can't get in touch with a patient?
I attempt 4 times. Oh, I said I make 4 attempts.
Mm-hmm. Mm-hmm.
And that's it. Yeah.
Yeah, that's about what we did also. Yeah. And what percent did you reach? Did you say that? I'm sorry.
I didn't. It's a high percentage.
Yeah, over 50.
Oh, way over 50.
Yeah. Okay.
I was thinking over maybe 80.
80%, yeah. Has anybody studied this? Because this is really unique, I think, in my experience. That there's a
Demonstration labs, and one of them is, I think, at the Seattle VA,
Mhm.
Greater LA,
Yeah.
somewhere in the Midwest. I think so 4 demonstration labs, and they were supposed to be studying it as we build and fly it.
Mm-hmm. Mm-hmm. Yeah.
There were, I think, in a multi-year kind of grant to do some of that.
Okay, great. So we're a little bit behind time, but we will catch up for sure. And we'll go through these last couple of segments quickly so we end on time or a little bit early. So let's move on and segue from how we're going to do the phone calls to what the content of the telephone call is. So the objectives of this section are to understand the importance of the follow-up telephone call, learn to conduct the preparation steps, become proficient in completing the call, and learn to conduct appropriate post-call actions. So the phases, the parts, components of the post-discharge phone call are the preparation, and then the 5 focus areas of the call are to identify the patient's health status, about medications, which is really where the action is, appointments and tests, home services, and what to do if a problem arises. So the idea of the phone call in our minds is that it reinforces the teaching that's happened at the time of discharge. The patients, as we've said, are not at the top of their game when they're leaving, and there's some things they're not going to get quite right. 2 days later, half of them are doing something that's not quite right. We need to get them back on track 2 days later. So that's the overall purpose. And then the post-call intervention, so that the call is certainly not a social call. It's not, hi, how are you doing? I hope you had a good trip home from the hospital, but really what are the problems that you're having, and then what are the interventions that can be taken at the time of the call that can get people back on track to improve outcomes. And the outcome we're looking at is rehospitalization rates. So who is it around the country that could make these calls? In our research studies, it was a PharmD who did that. And we chose that because there was some evidence in the literature and a few studies in small studies where pharmacists had called after hospital and it seemed as if it was a promising new intervention. And because the medications are such a large part of what needs to be discussed at the time of the call. It could be the nurse, discharge educator, or whatever the name is going to be of whoever that person is, who is the dedicated person to do the discharge, since they know they have done the preparation for the after-hospital care plan, they have entered the information, they've produced the after-hospital care, and they've printed the after-hospital care, and they've taught the information, they know the patient well. So for an economy's point of view, why not have that person make that call to the person who they already know and they already know their data? Could be that person. It could be a nurse hired for that purpose, a special place that makes all the calls to all the patients. And again, there are options for all the things that we've talked about today, and we don't know the right way of doing any of these things. That's why it's good to see people doing it in a variety of different ways, and we're all going to learn a lot about what works and what doesn't work. Another option is that nurses who discharge the patient. It seems to me that also makes sense from an economy point of view, that the patient, the nurse knows the patient, knows the medications, may know the family, knows any issues that came up during the hospitalization, and at a downtime, if that exists in a shift, could make a call for the patient who was discharged a few days before to identify any issues that have come up. Or even someone outside, like the case manager or the social worker who was involved with the patient, who they also might be available to do the call. And as we mentioned also earlier, is staff from the primary care office. And I think that this option has many benefits, and that the transitions have two ends. There's the hospital part of it, and there's the acceptance part of it, the discharge part and the accepting part. And the hospital can only do so much. And the more that we activate the primary care practice to pull them back in, the better it can be. And the few places around the country who have done this have shown some really strong results. And then in the BMC health plan in Boston, which is doing Project Red on all their patients, it's the plan who calls it. So the nurses do the discharge advocate role, and the plan, wherever they are, makes the phone calls, the follow-up phone calls. They have the advantage of having all the plan services. They have mental health service, substance use service, alcohol service, all that sort of thing. So they can really direct people into, ongoing care for specific things. And that's a real advantage, I think. So we don't know, and people will do it differently, and we'll find out over time the pros and cons of each. So The patient contact information, so what information is necessary to make the call, need to find out what language they are and any need for an interpreter, designated support person the patient wants involved in the care so they could be part of the conversation perhaps. And then contact information about what's the best time to call, when are we going to call, and try to make the call around that time if possible, and the ideal time of day and the day of the week that would be good for them. And then further, in terms of preparing for the call, that the Gail who made these calls would review the health history. That was mostly and we would give her a packet of papers which included the history and physical, the admission history and physical, the discharge summary, the after hospital care plan, and the med rec form that we have at our hospital. Yes. And then she would review that information prior to the call. She would review the discharge summary to see if there's any issues. Compare the list of meds and the discharge summary with the after hospital care plan, and it wasn't so uncommon that there were discrepancies there. But we always believe the after hospital care plan because the nurses worked very hard at working with the team on that. But then later when the discharge summary was done, there would be discrepancies. Review the medication list in terms of dosing, drug-drug interactions, potential side effects, new medications from this hospitalization, any tapers that are going on, any high-risk meds. And of course, this is the advantage of a clinician doing the call in the sense that they can really look at improving the drug regimen, the medication regimen, in terms of the issues that are listed there. So when is the right time? Again, we don't know. Research will show this ultimately when the best time to call is. So we did it between 2 and 3 days, and we stopped after 4 days, and so many attempts, 4, I think, attempts of trying to reach them. Well, we recommend making a minimum of 3 call attempts at the day and time the patient reports they're available. And we also, at the time during the hospitalization, we had alternative contacts on our contact sheet. And sometimes we would call that alternative contact if we were unable to reach the patient in the way that they had said we could reach them. So what are the components of the phone call? The Gail would assess the health status, ask, how are you doing? Medication check of each of the medications, a clarification of the clinician appointments and lab tests, and be sure that those are days and times and all that they could still make it. Coordination of post-discharge home services, so the day the visiting nurse is going, the day the hospital bed is arriving, the day the oxygen is being delivered and the CPAP machine and all that, and review of what to do if a health or medical problem arises. So just to reinforce the things that happened at the time of discharge. So in terms of assessing the health status, ask about the reason for his or her health visit, any changes since discharge, manage any medical changes, and recommended seeking medical care. So this is actually delivering medical care, and that some people who do the call are better at it than not, and that she would call, in some percentage of cases, call the primary doctor to discuss the case, or she would call the resident team in the hospital to discuss the case, sometimes call the pharmacy to clarify medications, etc. So the potential interventions relative to clinical care are patient education, talk more about their diagnosis, what to do, symptoms that they have, etc. Review patient medication adherence, check any laboratory tests that have come back if they have since they left the hospital. Advise about adhering to the scheduled appointment. She sometimes would tell them to take a medicine that had been ordered as a PRN medication to say, okay, why don't you try that medication? It might help with your symptom if it was something that could help. She would advise the patients to call their doctor in some cases. In some cases, she would tell them to go to urgent care or go to the emergency department. Sometimes she would call the discharge educator in our system for more information about the patient to see and to clarify, what the plan was on discharge. Sometimes call the inpatient physician, sometimes call the PCP. Sometimes, in a few cases, arrange for a same-day appointment with the PCP if it was something that was non-emergent and could be done in the office setting. and then sometimes talk with the family. So there's a whole long list of potential interventions that could be emanated from the discussion in the phone call. So it's an action call, and people have to kind of be ready to do those things. And many of them are things that can help keep the patient out of the emergency room. So in terms of the medication check, that we would ask the patient to bring the medications to the telephone, and she'd say, okay, go and get your meds and bring them to the phone right now. We're going to go through them, and then go through the medicines one by one to see that the med list that she had, both in the discharge summary and the after hospital care plan, is the list that they have, and that they have each of those medicines. Did they get the prescriptions, especially the new ones? Did they go to the pharmacy? Was the script filled? Are they taking it correctly? She would review the name and the dose, when to take it, and why. Fill in any knowledge gaps they have about what they're taking the medicine for. Resolve discrepancies between the discharge summary, after hospital care plan, and what the patient reports taking. And sometimes we require, as we said, a call to the pharmacy, the PCP, or the hospitalist. And sometimes a second call with a patient would be necessary to clarify any issues that weren't addressed adequately. In terms of clarifying appointments and labs, confirm the dates and the locations, confirm that they can make it, confirm the correct phone numbers if they need to reschedule, motivate them to review the importance of the visit, that follow-up for people with heart failure is important to keep you out of the hospital, keep you healthy, keep you feeling well. Do they have transportation? If not, to explore those issues regarding transportation to see if alternative plans are necessary. If completely unable or unwilling to reschedule the appointment, then you may choose to do this if the patient still wants to attend. That means to reschedule the appointment, but only a few times was that done, because that's sort of, we thought, beyond the call of duty on our part to actually reschedule appointments, so we didn't do too much of that, but sometimes. So this is an example of the communication with the primary care physician from our pharmacist who made the phone call. So she'd write, "Dear Dr. Doe, your patient, Ms. Suarez, was admitted to University Hospital for heart failure and provided the comprehensive red discharge. Mrs. Suarez was discharged on October 9th, and a nurse practitioner called him on October 22nd, 2010. During his admission, the patient revealed through a medical interpreter the use of a healer who considers hypertensive medication to be harmful. A family meeting was held, and his brother agreed to discuss the doctor's recommendation to use metoprolol with the healer. During the call, the patient reported that he had stopped taking metoprolol due to experiencing fatigue, which to him confirmed the healer's warnings. Mr. Suarez is scheduled to see you on November 10th, 2010. We have moved the appointment to October 27th to better monitor Mr. S.'s condition. The med list was updated in the EMR. Please feel to contact me with any questions." So you see there's a fine line between in reinforcing the discharge plan and working with the patient to keep them going until they can actually get to see their primary care physician. So that's one example. Another example of intentional patient non-adherence. Mrs. K reports in the post-discharge call that she always gets a headache with taking Iserdil, but was discharged on it. The prescription was waiting at the pharmacy to be picked up. The PharmD called the cardiologist, who recommended a lower dose. The PharmD called the patient back and discussed the importance of taking the medication and the expected side effects. The patient agreed to resume taking the medication and will keep the appointment with the cardiologist in 4 days. A note was faxed to the cardiologist and the PCP about what was done during that visit. This is an example of system clinician factors that were addressed sometimes in the phone calls. Mr. K had a CHF exacerbation and was discharged on furosemide. The red post-discharge phone call, was found that the patient was not using a diuretic, as the patient did not get a script on discharge. The pharmacist spoke with the inpatient physician, who faxed a new prescription to the pharmacy, and a written note was sent to the provider. So number 4, in terms of the list of components of what's done on the phone call, is coordination of post-discharge home services. and that is to review home services and contact numbers that are scheduled and listed on the after hospital care plan. And what to do if a problem arises, end the call by reviewing what the patient, and by reviewing with the patient and identifying support person, and what to do if a problem arises. Okay, so we have a case that we just want to go over with you. Do we have the? And I was going to ask David if you could help me. Could you? Is the other microphone? I'll get your chair. That's it.
You're not seeing it today, John.
Okay.
There you go.
This is Provena Hospital. We'll just change that to Palo Alto VA. That's my copy.
This is the one I read this.
You read blue. You're the patient. Patient's blue.
Okay.
Okay.
Oh, you don't need a mic. You have one already.
Oh.
Your mic is on.
I forgot.
Dr. Jack.
Hello, Mr. Smith. I'm Brian, a nurse from Palo Alto VA. When you left the hospital, your discharge educator mentioned you'd received a call checking in on things, and I'm glad to help with this call. I'm hoping to talk to you about your medical issues to see how you're doing and if there's anything I can do to help you.
Nice to hear from you.
Do you mind? Do you mind if I ask you a few questions so I can see if there's anything I can help you with?
Okay.
Is this a good time to talk?
No. Yes. Yeah, sure. Go ahead.
It'll probably take 10 or 15 minutes depending on the number of medicines you're taking.
That's okay. It might help as I want to do the best I can to get better. Did you know my granddaughter is getting married next year? She's the love of my life. I didn't make that. That's part of the script.
Before you left the hospital, Lynn, our discharge educator, spoke to you about your main problem during your hospital stay. Using your own words, can you explain to me what your main problem or diagnosis is?
Yes, I was admitted for congestive heart failure. It was the second time last year.
Could you tell me something about your understanding of heart failure?
Oh, my ankles swell. I get short of breath.
Mm-hmm.
Can't sleep at night.
Okay.
Depressed.
Okay.
Feeling suicidal.
We'll be sending somebody over to see you soon. What did the medical team tell you to watch out for to make sure that you're okay?
Yes, they told me to take my meds, weigh myself daily, eat a low-fat and low-salt diet, and to weigh myself every other day. And if my weight increases by 2 pounds, to call the nurse in my doctor's office.
That's fantastic, Mr. Smith, or Miss Smith. Are you able to do those things?
It's Renfro, Mr. Will Do, and yes, I try to stick to it as best I can, except at Easter when I always have ham.
Since you left the hospital, do you feel your heart failure has improved, worsened, or not changed? What does your family think?
I think I'm about the same. So does my family.
Have any new medical problems come up since you left the hospital?
No, but my weight's down to 142. Which is 2 pounds more than when I left the hospital.
Okay, Mr. Renfro, can you bring all your medications to the telephone, please? We will review them during the call.
Okay, give me a minute.
Okay, could you please go get your medication so we can talk about them?
I said give me a minute already. Okay, I have them now.
Do you have all the medications in front of you now?
Yeah, somebody was on a red eye last night. I got them.
Okay, I'm going to ask you a few questions about each one of your medications to see if there is anything I can help you with. We will go through the medications one by one, both prescription medications and over-the-counter medications. Over-the-counter medications are ones that you buy at a drugstore without a prescription. Also, we'll go over any herbal medications you may be taking. First of all, I want to make sure the medicines you were given were the right ones. Then we'll discuss how often you've been able to take them and any problems or questions you might have about them. Is that okay?
Sure.
Okay, choose one of your medications to start talking about.
This is my small white pill. Good choice of colors. Do you know it? I have taken it for a long time, but the name is different.
Oh, what is the name of the medication? The name should be on the label.
Furosemide. That is hard for me to say. I used to take something that looked just like this called Lasix.
Oh. So have you been taking both Lasix and furosemide?
Boy, that is confusing.
Yes, furosemide and Lasix are the same thing. Yes, it can be very confusing for people. What is the strength of the medication? It should say a number in a unit, such as milligrams or etc.
20 milligrams, one pill every morning.
And how do you take this medication? And what time during the day do you take it?
I take it in the morning because it causes me to, pee a lot, but not so much lately.
I noticed in your records that the doctors in the hospital had increased your medication so that you are supposed to take one pill in the morning and one pill at night. Were you aware of that?
No, I was really rushed when I left the hospital. A nurse gave me a form to sign that has my meds on it, but I can't understand it. So I'm taking what I took before I went to the hospital, the ones my doctor told me to take.
Do you know the reason that you're taking Lasix?
I know it makes me pee.
Yes, it helps you to remove the extra fluid from your lungs. Are you okay with taking a second pill in the evening until you see your doctor next week?
Sure, that's okay.
At this point, all the meds are reviewed, and it was also discovered that the aspirin that she is supposed to take was left off her discharge list. She agrees to begin taking.
You're mixing your patients up. I am Mr. Renfro.
Okay.
Mrs. Smith is not in the room. This is why we have events at discharge.
Okay. Have you been using the medication calendar in your after-hospital care plan that was given to you on discharge?
Yes, and I love it a lot. It helps me keep track of all of my appointments.
Now I'm going to make sure you and I have the same information about your appointments and the tests that are coming up. You're given appointments with your doctors for lab tests when you left the hospital. Can you please tell me what appointments you have scheduled?
Sure. I have an appointment with my cardiologist next Tuesday at 3 p.m. in his office on Main Street.
Great. How about the appointment at the lab to have your Coumadin checked?
Oh, yeah. My son was not able to drive me that day. He's been out of work and just got a job, so he could not take me that day.
Let's talk about how we can work around those difficulties. Would it be okay if I called the home care service and asked if they could go to your house to have your blood drawn?
That would be wonderful. You are so nice, Dr. Jack. I think I would have ended up in the hospital again if it weren't for this phone call. Palo Alto VA provides wonderful care, don't they? It seems as if they really care about me.
Thank you very much. $142.